Hello and welcome. My name is Dr. John Powell, and I'm the Continuing Education Specialist with the UNC Cancer Network. I'd like to thank you for joining us for our North Carolina Community College Lecture Series today, February 11, 2019. Just a few things before we get started. If you need to reach us for any technical difficulties, please call 919-445-1000. Once again, that's 919-445-1000. We have technical representatives standing by to help you out and solve any issues that you might have. You can also reach us by email at unccn@unc.edu. We're on the web at unccn.org, and you'll find many resources on our website, including all of our past community college lecture series. You will also find them on our learning portal at learn.unccn.org. You can complete any of our past lectures and receive certificates of participation for any of those previous lectures on our learning portal. We'll have a certificate available for this lecture in about 2 weeks. We're on Facebook, Twitter, and LinkedIn. We'll be using Poll Everywhere today, and we hope that each and every one of you will participate. There are several questions prepared, and you can interact with the presentation and our presenters today through Poll Everywhere. The easiest way to connect through Poll Everywhere is to go to a web browser on a smartphone or on your web computer. You can go to pollev.com/UNCCN. Once again, that's POLLEV.com/UNCCN. You'll see the questions as they appear on the screen. You may respond to them, and you'll see on our screen exactly what the percentage results are for all of our participants. You may also use a smartphone or any phone with texting capabilities. Just type 22333 in the to field and UNCCN in the message field. You'll do that one time. You'll receive a message saying that you've joined, and then you can just select the appropriate letter corresponding to the answers and submit those through your text app when the questions come up. At the very end of our presentation, we'll have an opportunity for you to ask questions through Poll Everywhere, and you can either use the texting functionalities or go to pollev.com/UNCCN. We do have a lecture evaluation survey. It's up at unccn.org/eval. Once again, unccn.org/eval. Please fill out this evaluation as it helps us to know a little bit about you and to know better how to make this and other presentations better. So we really count on those surveys. Please help us with that. I mentioned Poll Everywhere. This is our first question, so you can see it in advance. We'll go through the answers, your responses, in just a moment. But first, let me introduce our speakers. First, we have Hazel Hampton, who serves as a nurse navigator for head and neck cancer patients. She assists patients as they navigate through their complex treatment protocols. As a nurse navigator, she works closely with the patients and their families to ensure that they are well informed about the multiple treatment modalities utilized in modern cancer treatment. Welcome.
Thank you.
And we also have Stephanie Shea, who has spent most of her career working in oncology as a bedside nurse and infusion nurse, administering chemotherapy, coordinating clinical trials, and for 42 treatments. She now works as a nurse navigator, helping patients and their families navigate the complex and often frightening trajectory of cancer care. Welcome, Stephanie.
Thank you.
All right. Let me bring in both of our speakers. There we go. And as you can see, we now have the Poll Everywhere question. If you would, go ahead and put in your response. Which of the following is not a head and neck cancer? A is oral cavity, B is pharynx, C is larynx, D is nasal cavity, E is salivary glands, and F is liver. Which one do you believe is not a head and neck cancer? We'll wait just a few moments, make certain everybody has a chance. Okay. All right, looks like people are having a little difficulty. We'll please try to log in to Poll Everywhere, and we'll catch up with you when we get to the presentation itself. All right, we're very glad to have each of you here today. I'm going to pass the keyboard and mouse over. All right. And Stephanie will start.
Okay. Thank you very much, John. Good morning, everybody. So I wanted to start, before we can talk about what cancer is, I thought that we should discuss the characteristics of a normal cell versus a cancer cell. We should start with the objective. Sorry about that, I got ahead of myself. We're going to go over several things regarding head and neck cancer. And at the end of the lecture, you should be able to identify the major treatment modalities and at least 3 major side effects of these treatments, describe the modifiable and the non-modifiable risk factors for cancers of the head and neck, as well as signs and symptoms. And last but not least, we want to discuss the emotional impact and the quality of life issues that people have with cancers of the head and neck. And so now I'm caught up. So now I would like us to kind of review the characteristics of a normal cell versus a cancer cell. And I'm going to try to see if that little video will work.
Here, pass me that.
Okay. So normal cells, they grow, they do their job, they divide into daughter cells, and they repeat that process a set number of times, and it's different for each type of cell, and then they die. The lifespan of a red blood cell, for example, is different than the lifespan of a skin cell. So normal cells are also able to repair themselves when they're damaged. If they can't repair themselves, they kill themselves. They also stay where they belong, and they respect cell boundaries. And what that means is that the cells that make up your heart stay in your heart. We aren't dragging miles and miles of skin around with us. And that's part of the many different characteristics that makes a cell normal. And when a normal cell gets damaged, and this happens frequently, constantly in our body, there's mechanisms in place in the cell for it to repair itself. And if it can't repair itself, it causes itself to die, and this is called apoptosis. Now, a cancer cell is a cell where the damage is done to the mechanism that allows the cell to repair itself, or the mechanism that tells itself to die. So this damaged cell keeps dividing, complete with the original damage, and it doesn't die, and it divides rapidly. And each division is a more careless copy of the previous version. Over time, the cell division becomes more haphazard, the cells are more primitive, and eventually it barely resembles the cell they started as. They don't stick together or respect those boundaries. So you have this accumulation of these cells that keep growing until it's observable in something that we know as a tumor. Now, not all tumors are cancerous, but cancerous tumors, they don't just accumulate in that tumor. They also are able to travel to other parts of the body. That's what you might know as metastasis. And
And now we're going to go over some of the anatomy that make up the head and neck cancer. We have the oral cavity, which consists of the mouth, the gingiva, the hard palate, soft palate, the palatine tonsil, and then we have the tongue as well. Then there's the oral pharynx cancer. And along with that, there's larynx cancer, esophagus, and the tracheal vocal cord and vocal cord fold is also a part of that. Sorry.
no, that's okay.
Okay. And here we have again more anatomy of the head and neck cancer. As part of that, there's also the paranasal sinus that's part of it, and as we mentioned in the previous slide, I believe, nasopharynx. And part of the pharynx is nasopharynx, oropharynx, and hypopharynx. And then we have, as part of the head and neck as well, we have salivary glands. There's 6 major salivary glands that can be affected. We have minor salivary glands as well, but the 6 major would be submandibular and the the parotid salivary glands and sublingual.
Okay, so what is head and neck cancer? It's actually, it's not one cancer. As you can see from the anatomy slides, the head and neck has an awful lot of parts to it. So, and cancer can grow in any of those parts. It typically starts in the lining of the cells, the mucosal surfaces in the head and neck. Those cells that line these areas are known as squamous cells. And since about 90% of head and neck cancers originate in the squamous cells, our discussion today is going to cover those, that type of cancer. And we divide those cancers into 3 general areas: the nasopharynx, the oropharynx, and the hypopharynx. And just a few statistics, that head and neck squamous cell carcinomas, they make up about 4% of all cancers in the United States. However, it's relatively rare in the United States. However, in China and Southeast Asia, it is a huge problem. It is definitely in the top couple of cancers out there, and we'll get into why that is in just a minute. And it might be interesting to note that about 70% of these cancers are estimated to be avoidable by lifestyle change. And then we're going to also get into the HPV, the human papillomavirus, a little bit, because that has been seen to be a big player when it comes to head and neck cancer.
Okay, and here we have a picture of a oral cavity cancer and some epidemiology of the oral cancer. 95% of squamous cell carcinoma is part of what is the head and neck cancer or oral cavity cancers. And the average age is 60 years. The male to female ratio is 2-to-1. And tobacco and alcohol are synergistics. Betel chewing, poor oral hygiene can contribute to the oral cancer epidemiology of the oral cancer.
So it should be noted that, like what Hazel said, it's smoking and drinking together are synergistic, and by synergistic meaning that the 2 behaviors together make up a much higher risk than just smoking or just drinking.
Okay.
So the smoking and the drinking is a big risk factor. Poor oral hygiene, being male, and the betel leaf chewing, and that is why head and neck cancer is such a problem in Southeast Asia. This is a huge thing that a lot of people out there do. It seems to be similar to when people are using dip. They put this betel leaf, this betel nut wrapped in a leaf with some tobacco, and they put it in between their cheek and gum, and they keep it there for hours or even days. And that has been determined to be more than a risk factor, I think an outright cause of head and neck cancer out there. Including, they also use a lot of preserved salt cured foods, so that is a contributing factor also. And then there's one more. and the HPV, which we're going to talk about in a bit.
And so when we talk about some of the risk factors of things that we can change, the tobacco use, alcohol consumption, these are all things that we can practice as lifestyle changes.
I'm sorry, hold on a second. Okay. We have a little problem here in that the next YouTube video decided to play. But, sorry.
All right.
That's okay. Thank you. So here at UNC, we have as part of our multidisciplinary approach team, we use a huge multidisciplinary approach when working with our patients at UNC. And the head and neck, it consists of the surgeons, the medical oncologists, radiation oncologists, navigators, clinic nurses, psychosocial support teams, social workers, and also our UNC tobacco treatment program, which unfortunately is slightly underutilized, and we're working on that. We encourage people to always refer patients to the UNC tobacco treatment plan. It's a good place to start to get the patient introduced to the social workers for counseling so that they can work together with the patients on some of these lifestyle changes that they can do to help with the prevention of the tobacco use and, one of the main causes of the head and neck cancer along with the HPV. And we're going to talk about that a little more in detail about the vaccine and the preventive measures that we can do.
Okay. All right. So what are some of the signs and symptoms of head and neck cancer? The first thing, and you can see in the picture right there, something called leukoplakia. And that is it's a white patch that can grow anywhere inside the mouth in the mucous membranes. It can't be brushed away or scraped away. It just kind of stays there. It's considered a precancerous sign, and something that's precancerous won't necessarily turn into cancer, but it's definitely a pretty big warning sign that, and it would need to be followed really closely. Other signs can be a sore throat that doesn't go away, voice changes or hoarseness, difficulty chewing, swallowing, moving your tongue around. Sometimes people have a lump with or without pain that they can feel or see, or sometimes persistent nasal congestion that's not related to allergies or colds. So don't worry the next time you get a sinus infection that you've got cancer. This is something that's just not related to anything else. And also loosening teeth or dentures that no longer fit. These are some of the major signs and symptoms. A lot of times, when people go to the dentist will do a cancer check and they'll look inside the mouth underneath the tongue. And a lot of times that's the first stop for people when they feel or see something kind of funky in their mouth, that a dentist will take a look at it first. Okay.
Did we get too far? Okay, we have another poll question. When it comes to modifiable risk, actions people have control over, for cancer prevention, there are many myths. One common myth is that there are vaccines that can decrease a person's chance of getting cancer. True or false?
That is true. I think it put it. Well, it's working now.
We have some responses now. We'll wait just another second to give other people a chance to chime in. How are they doing?
They're doing very well.
Yep.
So
I guess it's actually not really a myth. That's sort of a trick question. There is a vaccine that can decrease a person's chance of getting cancer, and we're going to talk about that right now.
Okay.
And so, what is HPV? HPV is the human papillary virus. It is most common cause of sexually transmitted infection in the United States. It is transmitted through intimate skin-to-skin contact, and nearly all sexually active adults will get it at some point. HPV is thought to be responsible for up to 60 to 70% of oropharyngeal cancer, nearly 90% of cervical and anal cancers, 70% of vaginal and vulvar cancers, 60% of penile cancers.
I wanted to add that there's actually more than 100 types of HPV of viruses, and at least 14 of them are known to be cancer causing. Most sexually active people will be infected with HPV, possibly more than once, and you won't even know it. It clears up without treatment, and it's often something that just kind of comes and goes, and nobody ever knows that they have it.
We're going to hang out here for just a little bit on the Gardasil viruses. Whenever the virus first came about, they were vaccinating, I want to say, the children 11 and younger, and they were trying to capture the population of children before they were sexually active. And that's why in the previous slide we asked the question, if there was a vaccine that you can give to prevent cancer, would you give it? Would you do it? Would you have your family member get it? So now, more up to date with the vaccine is now being given to individuals to include age 27 to 45. So we encourage you to speak with your primary care provider about the vaccine and to speak to the pediatricians for your children that are of age to get it as well. So,
Sorry. No, that's okay.
Treatment for head and neck cancers, there's a tri-modality, surgery, radiation, and systemic therapy. Surgery is considered to be the primary, most important treatment. It involves the tumor as well as any involved lymph nodes, and with the hope that the cancer will be removed. The surgeon tries to make sure that the margins are negative and that the margins are negative, and I'm going to show you a picture and then I'll go back.
Oh, we have another question.
I'll let Stephanie do this poll question first.
Okay. So here is a question. Chemotherapy provides the best chance for survival in most head and neck cancers. True or false?
And we'll give everybody a few seconds so that they have a chance to respond. So once again, chemotherapy provides the best chance for survival in most head and neck cancers. True or false? Looks like people are having trouble again. Would you like to let them know the answer?
That is actually false. Like Hazel said, and she's going to continue to talk about, that surgery is really considered the most important treatment for most head and neck cancers, depending on the size and location, of course.
Correct. And like Stephanie was just saying, that's going to depend on the size and location as far as treatment being the first line of therapy. The burden of the tumor can also play a key role. I was trying to get to a picture. Here's a picture. So this picture shows you one of the best case scenarios where the tumor is excised and the patient had on my right hand side, I'm not sure, it may be your left, that the patient had reconstructive surgery after the tumor was excised and clear margins and healed well. And
So, or I was just going to say, organ preservation is always the goal, but that's not always possible.
okay. And here are some examples of patients. This patient had a nasal cancer, and he had sinus involvement, and he had that was before, and he ended up with a prosthesis, and he also had larynx involvement where he was trached. He actually had oropharyngeal cancer. And here is a patient that had tongue cancer with reconstructive surgery. Typically, with the reconstructive surgery, they'll do a forearm flap, or they'll do tissue from the thigh. And a lot of our patients will receive radiation therapy after surgery, post-operative. The radiation therapy for head and neck is 6 to 7 weeks. We have a lot of Lineberger trials going on here at UNC. And again, it's 5 days a week, 6 to 7 weeks. The first appointment is initially a consult where the radiation oncologist meets with the patient, talks about the signs and symptoms of the therapy and how we manage the symptoms. I tell patients that they're going to be the best person to tell us how to take care of them by communicating to us any symptoms that they're having. I tell them half of the battle of getting through the therapy is symptom management. And if we don't know, we can't take care of them. But if we know, collectively together with the multidisciplinary approach, we do a very good job of managing their symptoms. But again, we have to rely on them to let us know, because we may give them something. For example, if they experience pain from the radiation, we may give them something for pain that just doesn't work for them. And so we would have to change that treatment plan with the pain. And sometimes, no matter what the prescribing surgeon or radiation oncologist or medical oncologist will do to prescribe something for pain for these patients, they still don't get good pain relief. So then we have to pull in another member of our multidisciplinary team or pain management team to help get their pain managed. I'm going to talk a little bit more about the side effects of the radiation. Fatigue is a very common side effect.
Just slide.
Sorry. And so there's mouth sores, mucositis is a side effect. Dysphagia, difficulty swallowing, they have difficulty speaking, taste alterations. Some of that taste alterations is because of the salivary glands are often affected by the radiation. And our salivary glands, we have to tell patients that this may be a lifestyle change for them. With the dry mouth, we encourage them to carry bottled water around. We give them a simple household solution, salt water, baking soda, and we tell them to do that frequently throughout the day. There are over-the-counter agents they can buy. There's Exalamel, biotin, and then there's the radiation dermatitis. We have some really good photos of that. I'll let Stephanie pick up from the dermatitis.
Okay. So the radiation dermatitis, it occurs on the skin right at the site of radiation, as you can see. It's kind of like a sunburn, only instead of being burned by the sun, you're being burned by the targeted beams of radiation. Radiation dermatitis, it can be as mild as a tender burning redness like a sunburn, or it can be as severe as skin alterations and necrosis, which is not shown here. In addition to the pain, which in and of itself is very difficult to manage, as Hazel was saying, keep in mind also that this is occurring on a part of the body that is exposed, so it's a difficult wound to hide.
And I'm going to talk a little bit more about the patient as a whole. Our patients in head and neck, they suffer a lot of body images, so we have to consider this in our care plans and caring for these patients, which is another reason why we use such a huge multidisciplinary approach with calling in our psychosocial team as needed. We try to do a lot of educating these patients up front before surgery. We believe that the discharge starts at the time of admission, and for us at the time that we first meet them in the ambulatory setting to talk about any prosthesis devices that they would need. And they meet with our speech pathologist, not so much to counsel them on speech and pronunciation, but to help with their swallowing, because a lot of them, like we had in the previous slides, will have dysphagia either from the radiation or the surgery itself. So the speech pathologist meets with them before any therapy to assess them up front and then follow them throughout the course of treatment so that they're familiar with them and their swallowing habits, and to work with them from where they are in the beginning to as they may progress through treatment and have difficulties, to get them to a good place so that they can work with them to hopefully get them to continue to eat. A lot of outside institutions will, whenever they know that their patients are going to have radiation, they will up front put gastric tubes in. We don't do that here at UNC because of the huge multidisciplinary approach that we take with the nutritionist being on board up front. She usually sees the patients within the second week of radiation, their radiation appointments. So together, collectively, with the radiation team seeing them 5 days a week, Stephanie seeing them once a week for the 7 weeks, along with the providers there. We do a good job of supplementing our patients with nutrition, ensure and boost as needed, and then the nutritionist also works with the patient to make sure that they're having a high caloric intake.
Okay, and I can talk about the systemic therapy. Before I move on to the systemic therapy, I kind of wanted to also mention regarding the side effects that we were talking about under radiation therapy, and this goes for surgery, radiation, or the systemic therapy, but fatigue and depression is a very, very real concern. These patients, they're going to radiation every single day, 5 days a week for 6 weeks, and that's exhausting. And this is combined with pain and the discomfort that gets in the way of their sleeping. And all of a sudden, the most basic elements of living, breathing, swallowing, speaking, become difficult or impossible. There's always a pain involved with this treatment, and unfortunately, it's often visibly disfiguring. So depression is also a common thing that we address with the patients. Systemic therapy includes traditional chemotherapy, targeted therapy, and immune therapy. Now, unlike surgery and radiation, which are targeted directly at the site of the cancer, systemic therapy is usually, but not always, a medicine given through an IV, and it travels throughout the whole body. When it's used, it has a different purpose depending on the timing of its use. And it is rarely the primary treatment. The primary treatment is almost always either surgery and or radiation. When it's used before the primary treatment, whether that's surgery or radiation, we call that neoadjuvant or induction therapy. And the goal of induction therapy is to shrink the tumor enough so that the surgery or radiation is more successful. And sometimes if the tumor shrinks enough before the surgery, it allows for a better chance of organ preservation. Sometimes chemotherapy or systemic therapy is used at the same time as radiation. This is called concomitant chemoradiation. Oh yeah, I went in the wrong order there. And this time, the chemotherapy is used as a radiosensitizer. And what that means is it's used to make the radiation actually work better and make it stronger. The radiation is given every day. The chemotherapy is given either once a week or once every 3 weeks. And this combination is a great combination for cure. The downside is that it also makes the side effects worse. Other times the systemic therapy is used as the primary treatment. That's not entirely accurate. It's used the only treatment, and this is usually after the primary treatment has been done, and this is kind of done to mop up whatever microscopic disease might be left over. And it's also used when it's been determined that the cancer isn't curable, but the chemotherapy can slow the progression. And when that happens, it's called palliative care. And then side effects, they depend on the person and the drug. For example, a woman who has a lot of nausea, morning sickness while she's pregnant is most likely going to have to, we're going to have to address the nausea and vomiting during chemotherapy. Fortunately, we have a lot of really good drugs that can minimize or even prevent that side effect. Conversely, a long-term heavy drinker may not have any nausea or vomiting at all, and they may breeze right through. And these are examples of the main drugs. I won't talk too much about them. Cisplatin is the gold standard for head and neck cancer. It's been around for decades. It works well, but it is a traditional chemotherapy, and it has the kind of side effects that you typically expect when you hear about chemotherapy, like the nausea, vomiting. People don't usually lose their hair, however, but the decreased blood counts, the compromised immune system, and many other side effects, but it's the ones that you expect to hear about when you hear people saying that they're on chemotherapy. Cetuximab is called targeted therapy, and while chemotherapy attacks all the cells in the body, targeted therapy binds to specific receptors that attach to the cancer cell and that would trigger it to grow. This is a drug that is usually really well tolerated because it is so targeted towards the cancer cell. The main side effect of cetuximab is an acne-like rash, and that can be severe, but it typically goes away once the drug is stopped. And immune therapy is the newest form of systemic cancer treatment, and you've probably seen commercials for Opdivo or Keytruda for lung cancer. At this time, these drugs are only used in advanced head and neck cancer. They do not cure the cancer, but they can keep it at bay for a long period of time, sometimes even years. And these drugs work by allowing the patient's own immune system to destroy the cancer cells. It works on a genetic level, not the tumor. So when it works very well. It's typically very well tolerated. Most patients have no side effects to it at all. When there are side effects, they're usually related to the immune system being revved up, and we keep a close eye on that by asking about certain symptoms and looking at lab results.
We have another poll everywhere question, and once treatment is complete, if the cancer is considered cured, nearly all patients are able to resume life just as it was prior to diagnosis. And that would be A for true and B for false. And we already have one or more people voting. Just another second or two to give more people a chance. All right, once again, A for true, B for false. How are they doing?
Perfect. Can't fool them. All right. So So no discussion of cancer is complete without a discussion on quality of life. Once a person hears the dreaded C word, their lives really take on a whole new perspective. In head and neck cancer, the cancer and the treatment itself is typically very visible. It's not just that the bald head of chemotherapy. People understand that when they see somebody with a bald head and a scarf, they understand, oh, this person has cancer, they're going through chemotherapy. With head and neck cancer, it's different. They don't always lose their hair, and they can be fairly disfigured. Most body parts that get cancer are under the clothes or under the skin, but head and neck cancers are hard to hide. It's considered to be really one of the most debilitating cancers. The most basic survival needs, breathing, eating, communication, these are all affected or can be all affected by the cancer and the treatment. And it causes defects, not only in how the person looks, but how they function with things like breathing, eating, and communication. Our faces are the most visible part of our anatomy. The disfigurement that comes with these kinds of cancers can really affect a person's self-esteem. Social interactions become just so much more difficult. Eating at a restaurant, going out and having a drink with someone may be impossible. So patients can become isolated, angry, depressed. Also, much like lung cancer, head and neck cancers are associated with heavy alcohol drinking and smoking. So patients feel guilty that they asked for it or that they somehow deserved it or brought it on themselves. And they might even be told that by others. So in addition to that guilt of feeling that they caused it themselves, they feel ashamed with how they look or the degree of disability, whether they're living with a tracheostomy, talking with an artificial voice box, or having unintelligible speech, or having difficulty with secretions that they can't get rid of. Also, the pain that's associated with cancer treatment, it usually goes away. It almost always goes away. However, during the treatment and for weeks or months afterwards, opioids are almost always used to address the pain. The pain can really be agonizing. There's no other way to put it. At UNC, the head and neck team is very cognizant of opioid dependence and abuse, and every patient has a plan to decrease and ultimately end their opioid use safely. This doesn't happen everywhere, however, and unfortunately, with head and neck cancer, a lot of times people can add opioid addiction to the list of just issues that they have to contend with. Fortunately, not as much here at UNC. And nutrition, swallowing, breathing, and communication, if not permanent, can take a great deal of therapy to adjust to this new normal. Dietitians and speech therapists, like Hazel mentioned a couple minutes ago, are positively critical members of the team. And of course, patients that have good social support, loving families, they fare a lot better emotionally and psychologically than those who don't.
And I just want to talk a little bit about those that don't have. We have a lot of patients that come and they don't have a supportive team. So with that, again, we're fortunate here at UNC where we can call in other members of our team, chaplain service. And I wanted to back up just a little bit and talk about having a plan for these patients from the time we meet them, before we take them to surgery, to especially the ones that will lose their voice. We have to establish how we're going to communicate with them, how they will communicate with us, and we have to assess their literacy. We have a lot of patients that come in, and I like to take our patients to our Family Resource Center, which in my opinion is one of the best parts of our oncology program. There's tons of literature there and lots of supportive staff. but it would do the patient no good to hand them a bunch of literature on signs and symptoms and how we're going to manage them if they can't breathe. So we need to assess these things up front. And I want to back up a little bit further to the surgery aspect of it. I talked about the surgery with that a lot of times being the first line of treatment, but I failed to talk about what would cause the patient to have the postoperative radiation and chemotherapy. Again, that would depend on the tumor burden, the margins, if there's any lymph nodes involvement, if the margins are not all negative, and if there's any metastatic disease. That would buy those lateral things that I mentioned will buy the patient postoperative chemoradiation. And then there's times when the margins are negative, and there may be one lymph node or two lymph nodes, but we'll say one lymph node that was removed, but the team, which consists again of the medical oncologist, radiation oncologist, the pathologist, the radiologist, they review the records, and based on evidence-based practice, they'll say, well, this patient could benefit by having a course of postoperative chemoradiation or maybe just postoperative chemotherapy. So these are things that would buy our patients that trimodality or postoperative radiation therapy.
So this is the last slide. We're just about to wrap up. It's not all bad news. Between the pictures and the side effects and everything, it sounds like a pretty grim cancer. It is a very, very difficult cancer to have to go through. However, unlike most cancers, head and neck cancers can be and often are cured. I don't know that anyone would volunteer to go through that kind of a difficult process, treatment of going through all that pain, if it just meant a few extra weeks or months of life. So as nurse navigators, that's one of the things that we remind our patients of a lot, is that as difficult as it is to go through, the goal is cure. So that's the payoff. We try to keep that. It's very hard for them to remember, so we try to kind of be their cheerleader as well, and remind them there is life after cancer. It might not be the same life, but it is definitely a life worth living. And when it can't be cured, when it cannot be cured, which unfortunately does sometimes happen, like many other kinds of cancers, it can be managed. Sometimes, as we mentioned earlier, for a long time, even years. And so in that case, we changed the view from treating a cancer as something that someone is, that we're fighting as, that they're going to die of, to viewing it more as a chronic disease like diabetes or hypertension. And so we now try to frame it as patients with cancer are living with cancer rather than dying from it. Thanks.
And another part of our team is, as Stephanie was saying, our patients that we are not treating for curative measure, and we have to call in our palliative care team. Very important part of our team as well, because, and we try to bring them in sooner than later when patient is, there used to be a myth that palliative care was for the dying. Well, now we bring them in sooner than we would want to put a patient on hospice. Back up a little bit more about the radiation therapy. The post-treatment side effects from the radiation therapy could last 6 months to a year is what I tell patients, and there's some evidence based that it can last even longer than that. So with that being said, we teach our patients that they have a new norm, and we encourage them to try to get back to where they were before they had cancer, but it's not always possible. So we teach them how to live with whatever their new normal is, but we encourage them to be as active as possible, to get back to resuming a regular diet, if at all possible. Wanted to add something else, Stephanie, about palliative care.
No.
And we also have a survivorship. We are moving towards survivorship care plans. And so we work with our patients at the end of the therapy on moving towards survivorship and survivorship care plans.
Yeah. Thank you.
Thank you both very much. And if you don't mind, I'll take the
Okay.
And our next, we do have the opportunity for people to ask their own questions now. And while we're waiting for people to post their questions, I have one or two. For those patients who are having trouble kicking addiction, such as tobacco or alcohol, what are some of the things that the team can do to help them?
So for the tobacco, we do have our tobacco cessation team, which is mentioned in the slide, and their information on how to contact them. And then with the alcohol, we have to refer them to the substance abuse team. Mm-hmm.
But there are resources there for
There are resources at UNC to help those patients. Some of these patients, we have to, when they're ready, get them to commit to an outpatient service where they go in and they stay for rehabilitation. We even have patients that we have to do this for before we bring them to surgery so that they don't go into crisis and withdrawals after the surgery. So we would send them to rehabilitation to try to get them withdrawn from alcohol before we do the surgery, because if not, that can make for a lengthy hospital stay in the intensive care unit after they have the surgery because of the withdrawals. Unfortunately, alcohol is a very bad drug. It's one of the worst drugs, excuse me for saying this, that they legalized, because a person can literally die from withdrawing off of alcohol if not in a safe environment with the right medication.
Mm-hmm. All right. And in North Carolina, what are some of the more common forms of head and neck cancer, and why do you think they are more often found in North Carolinians?
Tongue cancer is probably the most common. Mm-hmm. And the oropharynx, the one in the middle of that slide that was earlier, that area tends to be more caused by the HPV virus. But the other ones are very directly related to drinking and smoking. We don't really know what vaping, how that affects head and neck cancer yet. I suspect we're going to find that it's, a contributory factor, but smoking and drinking really is the number one combination.
And I think as to the question as to why is probably because of the tobacco being grown here, and they start smoking at an early age and chewing and sniffing.
So the prevalence of tobacco usage in the state, based upon the history of tobacco in the state.
Yeah.
Mm-hmm.
Right.
Yeah.
And in your experiences, what are some of the easiest or most meaningful ways to provide support to someone undergoing treatment?
In my opinion, it's utilizing the entire team. Just like the saying says that it takes a village to raise a child, it literally takes the entire team of us to get these patients through therapy. No one person can take the credit for it. Stephanie and myself, we try to tell patients that we are a very good contact person for them, and if we're not the right resource, our job is to get them to the appropriate resource. But again, it's a whole team of us that work collectively together for these patients to get them through, and even not just through the treatment, but like I said, the patients will call me with the post-treatment side effects from the radiation. And some of these side effects like the dry mouth, it may just be a lifestyle change where they're definitely going to have to walk around with bottled water for the duration. But again, it's the whole team of us that work for the patient to make sure, and I tell patients when I meet them, I work with the providers, but I work for the patient, and I try to make sure that they understand that if there's anything they need, any questions, any concerns, that they need to be calling one of us so that we can be busy trying to resolve them and make sure we're meeting their needs.
Yeah.
All right. Thank you so much. A few things I want to mention before in wrapping up. We want to thank the We want to thank the North Carolina General Assembly for their gracious support of the UNC Lineberger Comprehensive Cancer Center and for the University Center University Center Research Fund. Cancer Research. Excuse me here. All right. We want to thank all the folks on our team who make this possible: Dr. Thomas Shea, Tim Poe, Mary King, Veneranda Ogure, and Jean Sellers. Remember, I mentioned at the beginning of the evaluation survey, we really do need your feedback on these. And the surveys really are as short as what you see here on the screen. So please go to unccn.org/EVAL. It just takes a minute or two, and we really do appreciate your help. As I mentioned earlier, you can go to learn.unccn.org and find out for our learning portal, and there you can find many courses. Now, for our next live lecture we have on March 18, Caring for the Patient with GI Cancer, and that you'll find on our website, unccn.org. And then on our learning portal, the most recent courses that we have put in are Caring for the Patient with Colorectal Cancer with Tammy Triglianos, and Caring for the Patient with Melanoma or Other Skin Cancers with Dr. Nancy Thomas and Dr. Francis Colicchio. Thank you all for participating. Please be sure to take care of those evaluations. Visit us at unccn.org for our upcoming live lectures, and learn.unccn.org for our learning portal and previous courses. We hope to see you next time. Thank you. Hazel and Stephanie, thank you very much.
Thank you. Thanks for having us.
Pleasure.